From our 22 News Broadcast Center, this is 22 News in Focus.
Good Sunday afternoon. Welcome to 22 News in Focus. I'm Ashley Afonso. This week is National Nurses Week, which happens each year on the birthday anniversary of Florence Nightingale, the founder of modern nursing in the 19th century. Across the nation, hundreds of events will take place to commemorate the nursing profession and pay tribute to nurses for their work they do every day. In Western Massachusetts, there are thousands of nurses working at hospitals, nursing facilities, schools, jails, and in private practice. Some are visiting nurses who provide care in people's homes. And joining me today to discuss the nursing profession are Christine Klusnick, Chief Nursing Officer and Vice President of Patient Care Services at BAYSTATE Medical Health, Kara Chandler, Manager of Nurse Residency Program and Student Nurse Associate Program at BAYSTATE Medical Center. We also have Melissa Twomey, Director of the Professional Practice, Nursing Research and Quality at BAYSTATE Medical Center, and Michael Duffy, Associate Professor and Accelerated Second Degree Coordinator, School of Nursing at Elms College. So first of all, tell me a little bit about yourself, how you got involved in this profession.
So I really got in tune into nursing when my dad actually passed away at the age of 42 of a brain tumor, and that really, I saw how he was treated, and it really drew me into the profession. And it's interesting that actually oncology nursing was at the heart of where I started my career.
Working being a caregiver was a natural role for me, and I can remember, it goes back to when I was young, like probably around 5. I have memories of listening to my mother's friends who were nurses share stories about caring for others, and I thought, wow, that I was really impressed. And I even remember really wanting to spend time with one of my mom's friends in particular, because I loved listening to her, and I realized I wanted to be like her. I wanted to learn from her. I wanted to be a nurse.
How about yourself?
So for me, nursing actually was something that people had said I should look into, but I swore I didn't want to be a nurse. I was a bit more into science and academics, and I loved physics and physiology, so I actually went to school for physical therapy first. And while I was doing co-ops, I started realizing that there was this caring element that I was missing out on and the nurses were having. And so about 3 or 4 years into my program, I switched into nursing, and probably should have started there all along.
Probably at the core there was some caring piece, but I began my studies as a priesthood candidate, and I was working with exceptional children and realized that I didn't want to preside and lead people in prayer. I wanted to walk with people. So I asked for permission to go back and study nursing, and they decided they would test my vocation at a summer in a nursing home, and I haven't looked back since. That's 30-some years ago.
Wow. Well, thank you all for being here and sharing your stories. So first of all, let's talk about what Nurses Week is and how it came to be.
So Nurses Week is a national celebration. It runs from May 6th to May 12th. Usually May 12th is Florence Nightingale's birthday, and May 6th starts off the whole celebration as National Nurses Day. So at BAYSTATE Medical Center, we really acknowledge, we spend the whole week on it with daily events, educational opportunities, celebrations, nursing awards, really trying to recognize the work, the hard work that our nurses do at the bedside and the professional practice of nursing and where it's going. So it's really a call for the nation to understand the significance of the practice that nurses bring to the table.
What led to this Nurses Week?
I believe in the 1960s and 1970s, there was a cohort, I think it was under Lyndon Johnson, but I could be incorrect in that perspective. They just really wanted to recognize the work that nurses do. So they started off with one day, and then it led to a whole week celebration.
Okay, what drives people to become nurses? It has been a career that many people go to for decades now. What is it that drove you to it?
Why don't you take that?
Yeah, that's really easy to answer. It was something that is very meaningful, and I think anyone who's going to consider working as a nurse, those who are working as a nurse, find that it's inspiring. You're working, you're taking care of people at possibly the worst moments of their lives, and that is very impactful. You're watching your patients with challenges that can be life-altering, and being a part, and I love how Brother Michael said, having the opportunity to walk with them through that towards wellness is very meaningful.
Traditionally, nursing has been considered a woman's profession, but more recently we've seen a lot of men going into it. Why is that?
I think because of the caring, and that it's no longer problematic to say you're going to care. all those previous stigma are gone. When I started, I did apply to the Elms and was told we weren't taking men. Now we run 8 to 10 in our traditional, and about the same now in the accelerated. These are folks that are going back for a second degree. Maybe there wasn't meaning in what they were doing. Nursing gives more meaning to that, and I think I see that in the traditional students as well. They're looking for more than just a job. They're looking for something that has some feedback at the emotional, interpersonal level.
Would you say it's 50-50 now between men and women, or is there still a lot less men?
If we did the statistics, it would be well under. I think it's only 4 to 6% nationally. Yeah. So we're not talking big numbers, but definitely a shift, and more.
All right. Let's talk about the difference between an LPN and an RN.
So there's a lot of different ways that people enter the nursing profession, and just even locally, we have a lot of different types of programs. So the LPN is more of a technical degree focused on the bedside caring, the treatments and administering basics of care. The RN is actually a more academic degree, very focused on the background of the disease processes, understanding all the physiology, and also starting to think about the differentiator is that we can teach and assess. That's the biggest difference between the RN and the LPN. The LPN does a lot of data collection, blood pressures, things like that. The RN role, the differentiator is the expectation of that critical thinking about how all the pieces come together to formulate a diagnosis and treatment plan.
Okay, and how about a nurse practitioner and a nurse's aide?
Well, so those are very different. So a nurse practitioner is an advanced degree. It's an advanced education, and I'll actually let Brother Michael talk a little bit more specifically about the nurse practitioner piece. But just quickly, the nurse's aide, a lot of different reasons people go into becoming a nurse's aide. I actually started as a nurse's aide when I was going into nursing school. For some people, it's a great way to learn a little bit about healthcare before you make the big leap to go into a nursing program. You'll find a lot of CNAs, nurses' aides at long-term care. We do in the inpatient setting, and even in acute care, outpatient, you'll see PCTs, patient care technicians that are nurses' aides. They have training in toileting, ambulating, basics of caring. They're actually invaluable in the sense that they bridge a lot of the time that the nurse can't be at the bedside. The PCT or our CNA is the one that's there actually talking to the patient, connecting with them a little bit. But the
nurse practitioner, since '95, American Nurses Association has recommended that it be the master's prepared nurse that goes on for what we call now advanced practice registered nurse, with additional courses in pathophysiology and physical assessment and pharmacology, so that not only do you assess, but you diagnose and treat with or under doctor supervision. Find us in many primary care settings. The new movement since 2009 has been towards the doctorate nursing practice for the nurse practitioner, and a real differentiation between the family nurse practitioner and the acute care. And it mimics the current healthcare system. You see a primary care provider in the community, that would be a family nurse practitioner. And in the hospital, you see a hospitalist or an internist. And now for the nurse practitioner, it's an acute care nurse practitioner. And we're mimicking the same with pushing for the doctorate to be the terminal degree for that.
The other thing that I would add to that is that it's important to, it can be confusing for patients, but it's important to acknowledge that the NP is a certification. It's a credential that you earn through a testing process. There's a degree associated with it, but it is possible, and Christine is an example of someone with a doctor of nursing practice, who you actually are an APRN too, but you don't have to be an APRN to get a doctor of nursing practice. There are other fields in which you can go to the terminal degree in nursing practice without being an NP.
We just talked about a lot of different forms of nursing, but what is the traditional schooling like for a nurse?
Traditionally, 4 years in the area. Begin with your undergraduate basic sciences to support what you're doing, your A&Ps, your micro, your chemistry, psych, soc, etc. All those things that support nursing. Over the 4-year period, depending on the program, some have direct entry, so you might have one nursing course in your freshman year, Some don't let you start to your sophomore year. Others are upper division, they're only junior. I can speak for the Elms. We have them take 1 3-credit class in Introduction to Nursing in their spring of their freshman year, and then they take nursing courses in their sophomore year, with their fundamentals being their big transition to clinical practice bedside, and then their junior and senior year is all the tracks that have to be completed.
And just in addition to that, because we acknowledge the bachelor's degree is where we want people to go, but with the release of the Future of Nursing report and other reports locally, there's been a lot of work in really trying to enhance the diversity of the profession, and part of that is building a seamless pathway from some programs to another program, because not everyone is financially or even academically ready to jump into a 4-year program. But the underlying message that we tend to share is you can start in the LPN or the AD, but really keep going towards the BSN. And for some people, that provides a better pathway. They can work full-time while they finish their degree for the BSN.
All right. Nurses' roles, responsibilities, and education are changing to meet the needs of an aging and diverse population in a complex, evolving healthcare system. We'll have a discussion about that after the break. You're watching 22 News in Focus. Welcome back to 22 News in Focus. Today we're talking about Nurses Week and the issues facing the nursing profession. There are many daunting challenges facing the nursing profession and healthcare today: an aging population of baby boomers who will require more medical care, increased patient volumes, the acuity of patients, nursing shortages, and the debate over nurse staffing ratios. So let's begin by talking about some of the changes in the nursing profession over the past 10 years.
So I think in the past 10 years, we've actually seen a shift. I mean, patients are sicker when they come into the hospital as compared to when I was at the bedside over 35 years ago. The nurses today have to have an amazing skill set of assessments for the patients that they take care of. So that's a piece that's changing. In the outpatient world, as we focus on keeping patients healthy and keeping people out of the hospital, nurses are seeing expanded roles where they're really working with their provider colleagues, really trying to focus on diabetes, focus on high blood pressure, focus on the chronic conditions that patients really have to try to make sure that we keep them out of the hospital. We're trying to do our best to do that. More resources are needed, and technology is another issue that's impacting the workforce. You know, today everything is the nurse is attached to a computer sometimes, trying to make sure that we capture all the required elements for reimbursement for care with all of the changes in our Medicare and CMS requirements. So it really is a complicated position these days, much more complicated than when I was at the bedside.
You say patients are coming in sicker. Why is that?
Well, it depends on the patient's condition. You know, in this part of the state, actually, we have some of the sickest patients and underserved patient populations, because there really are a lot of poorer neighborhoods, very culturally diverse neighborhoods, people that are uninsured, you know, coming to the hospital for care. So it makes it more difficult and challenging.
Are you finding that people are not seeing their primary care doctor on a regular basis as well?
I don't know the answer to that, to tell you the truth. It really depends on the primary care practice, their access, their ability, and what patients really understand about where they should go.
Okay, let's talk about technology and how that's changed for the profession.
So the computer has actually changed everything for every piece of the profession, and my colleagues can help jump in about that piece. The requirements of data that we have to collect and put into the medical record for reimbursement purposes, for safety purposes for the patient, that has made it really difficult to really use the computer as your partner as we're really trying to demonstrate that we care for people.
It can actually present a little bit of a barrier. So another change that I've seen, even in, I think I'm coming up on 14 years now. So in the last 10 years, what I've seen is a lot of expanded roles actually related to the technology. So there's a benefit too, because now we have nurse informaticists, and we have a lot of, if you maybe wanted to be a nurse but got into it and thought, I don't know if I want to be doing the bedside piece forever, but you love computers, now there's a whole other place to bring that expertise to. But at the bedside, so much of our care, we have a lot of safety measures, in addition to all of the documentation and all of the things we need to charge capture, we have a lot of safety pieces too. We do barcode scanning to make sure that the medication matches with the order, that the right patient is getting the right medication. And even though nursing really is a tapestry of science and art, the science piece is becoming incredibly important, and sometimes those can feel a little bit task-oriented, which nurses don't love. We don't love the task so much as we love the people.
And the hope was also that they wouldn't have to read my handwriting, because it has improved our ability to communicate. It's helped with prescription writing and errors there in particular. So there are many benefits, though it has these other encumbrances that are just part of the job.
And that's a good point too, because I don't know if you've experienced this, but even in the past few years, it's getting a lot easier to schedule an appointment to get your medication refills. You just go online, and I mean, even people that before might not have been tech savvy, like my grandmother, you know, they're on there filling their refills and whatnot.
The other benefit I've seen that we haven't talked about, despite all of this hard work, is that from you mentioned medication administration safety practices, but we're also building science into preventing infections, preventing, say, catheter-associated urinary tract infections by standardizing the work and really get to high reliability as a science and a profession. We're helping patients stay safe.
And actually, just to add to that, because I don't know if this is what you were thinking of, but we've actually been partnering with organizations that can help with deep learning. So the computers now know more about our patients than we know about our patients in some cases, and can get down to, you're in a community that has a food desert. So it seems like, you know, you're in the middle of Springfield, you should have all the resources you need, but you may not have a place you can walk to get food, and that means that that's a risk for you when your disease process requires you to eat healthy.
Right. What Melissa's talking about is some of the work that we're doing at Baystate Medical Center using artificial intelligence, which is a new phenomena that is coming out in the healthcare world, and it's really helping us predict which patients might be at risk for developing a pressure ulcer because of the demographic factors that Melissa's talking about.
Wow. All right, some hospitals are seeing an increase in patient volumes, especially among baby boomers. Why is that, and how are you working through that?
You know, it's the opposite of what we predicted. When I actually was going for my master's, we were saying, oh, everybody's going to be seen in their primary care practices, and that's the way we're going to do it, and we're going to put nurse practitioners out into the community. Everybody's going to be really healthy. And right now, I think the issue of chronic comorbid disease, you know, the many different issues that patients might have are adding to the volumes. This year was an incredible year with the flu. The flu really hit every place across the United States really bad, so the volumes have been unpredictable. But I do think that hopefully with our work in population health, we'll get to a place where we'll actually be able to decrease admissions to the hospital.
Okay. Recently, the Institute of Medicine's Future of Nursing report encouraged nurses to take a greater role in an increasingly complex healthcare system to make their voices heard. How are you guys? You're here today, but how else are you getting out there and talking about your profession?
Does anybody want to take that?
I think there's a lot of diverse ways that you can participate. When I actually happen to teach a class where we talk a lot about this, and I usually say you're either driving the bus or they're going to run you over. So nurses want to be driving the bus. We have a lot of great ideas you want to share. Locally, I know that there are nurses that are participating in even Tech Spring, you know, in technology locally, developing new products. There's a lot of political action among the nursing profession. A lot of nurses not only work at the bedside, but also teach. They're out in the community. They're working. We have a lot of volunteerism. Nursing voices are all over the place.
I think one of the things for the School of Nursing is helping students come to understand and find that voice. If they don't, and when they first come, they're like, what do you mean find your voice? But the whole idea of finding your voice and speaking up and being able to articulate what you're doing, and not just I'm taking care or you're taking a back seat or the bus is going to run you over. So the idea of finding voice and using it in many and varied ways these days.
One of the other issues from the Institute of Medicine report was that, you know, trying to get nurses on boards. And so Baystate Health actually is very fortunate that Dean Scoble from the Elms actually was one of the first nurses to be put on our board of trustees. And so having a voice, being visible, being I'm a member of the Organization of Nurse Leaders, and we really try to make sure that we're advocating for roles of nursing in a variety of ways and making sure that legislators and others really understand the importance that nurses can bring to the table.
And the other thing too, to what you do with the residents, I think is worth mentioning, that it's a whole year of really learning how to bring your voice out.
The residency program, and I believe we're going to get to some of those questions in a little bit, but the residency program is a great platform that, it's been well recognized over the years as the healthcare landscape has changed, and the learning curve for new grad nurses is harder. And it's a year-long program, and they have the program includes all of their experience throughout the hospital, their first year of nursing, and it's complemented by monthly seminars where content experts come. And exactly that, they are encouraged. And I hear a theme, and it's how to share your voice.
All right. Thinking of entering the nursing profession? We'll learn more about the education requirements when we return. You're watching 22 News in Focus. You're watching 22 News in Focus. Today we've been discussing the nursing profession and how it's changed to meet the changing needs of the society. There is evidence that a more educated workforce, the better your quality of care and patient outcomes. The Institute of Medicine, recognizing the country's growing healthcare needs, has published recommendations that encourage more nurses to pursue advanced education degrees, and the National Academy of Sciences has called for 80% of nurses to have bachelor's degrees or higher by 2020. So what is the push for higher education among nurses?
I think, quite honestly, the push is, and you guys can chime in if you want to, that a highly educated workforce really relates to better prepared patient outcomes. At BAYSTATE Medical Center, we're pushing for the 80% bachelor's prepared nursing workforce. We're currently at 68%, so we make sure that we make progress. Our nursing residency program, which hires about 150 new nurses at the bachelor's level, is helping us to get there. And also, we focus very strongly, because we are a magnet organization. We have been certified, designated 3 times as a magnet organization, which really speaks to the quality of care that's provided. We're on a journey to number 4. Also, nursing certification in this specialty is a requirement when nurses want to advance to a certain level. So really focusing in so that you provide a special set of skill sets for your patients.
The movement from a bedside traditional path to critical thinkers who at bedside are putting the pieces together, and because they've developed voice, they're going to come forward and say, this is what have you considered this, the old S-bar, offer a recommendation, as opposed to, yes, we'll go change that bedpan. The idea being that critical thinkers will bring better outcomes in the end, and that happens with more education.
Okay, let's talk about some of the programs locally here.
So actually, Brother Michael and I sit on the Western Mass Nursing Collaborative, which is an organization of both healthcare organizations, that have an interest in improving the health in the area, but also focusing on how we can collaborate with the schools to pull everything together so that the academic preparation matches what we need in the hospital, and so that we're meeting their needs with, they need clinical placements. There's a lot of local programs. We have community college, we have STIC, we have bachelor's programs. I know the Elms offers all levels of nursing, bachelor's, master's, and doctorate.
Do you find a difference in curriculum between the programs, or is it generally very similar?
Depending on level, I would say. The associates tends to be similar, bachelor's tends to be similar.
But they each have their own flavor, to say,
yep.
And that's, we get the directives from the state board, what they're looking for. This is the minimum for safe practice to keep the public healthy and safe. And why is there an Elms, why is there an AIC, a Westfield, a UMass at the bachelor's level? Because each of us have a little different flavor. Yeah. Elms, we're going to go for that uniting neighbor with God, something in that domain. UMass, you're coming from a different perspective, AIC. So each of us have the same terminal objective, but how we get there is flavored different by the school we attend.
And they may have different, the faculty may have different interests. So you may go to one school that, I actually am from the Worcester area, so I'm thinking of, I knew that if I wanted to go into forensics, I would go to Framingham. If I wanted to go into You know, I went to Worcester State, which was closer to home and much more the generalist. There's a lot of different programs locally. If you want to specialize, you can look at a different program.
Do you have to declare a specialization as a nursing major?
No. At the bachelor's level and for your first sit, you're a generalist and you all are prepared at the same level. You can specialize thereafter, as Christine spoke about, even specializing with certifying in different areas, but as the new graduate, you're a generalist.
And we do encourage that certification. BAYSTATE has dedicated a lot of resources towards encouraging our nurses to sit for their specialty certification, but that specialty certification doesn't come until 2 or 3 years of expertise in a specialty. And it's a pretty comprehensive exam, and you really have to demonstrate expertise in that area.
Okay, let's talk about the Western Massachusetts Nursing Collaborative.
So as I mentioned, we both sit on it, actually met today, and we actually pulled together, as I mentioned, healthcare leaders in the area, both from the academic and from the hospital groups, and talk a little bit about, you know, the curriculum is a piece of it, but it's bigger than the curriculum. It's the diversity of the profession and pathways from one program to the next. And
by everyone playing in the same sandbox, so to speak, one can go from one to the other. So Mercy and BAYSTATE, and by everybody having similar concerns and similar terminal objectives to get in, then you're not one for this one for that one. One set of paperwork, one set of permissions, one set of this and that, and it makes it much easier on the students who are much less the professors and the coordinators, and BAYSTATE, who has to Cinnamon, who coordinates all of it for me, that it just makes it so much easier because it's more alike than different. And whenever you can make it more alike than different, it's just a little bit easier on everybody.
And it's been helpful to hear both perspectives. I know we've had some discussions to that point about requirements, thinking about how do we make it easier on the student? Because as the hospital, sometimes we say, well, we have a rule we have to follow, so we're going to put in place this process. And then we tell the school, and then the school says, well, that doesn't work for our students because, oh, by the way, they go home for the summer. They're not here. So we really want to make it as welcoming and as enticing as possible as a profession, and that's what we want to do.
All right, let's talk about some of the trends in the medical treatment field right now.
So trends, it's such a broad, actually, category that if you think about new things, there are always new things that are happening in intensive care medicine. In cardiology, there's new procedures. Urology, there's new procedures. So all of us really have to keep our nursing staff well educated and up to date as treatments in certain specific segments get expanded and are working differently. So we're always, Melissa and her team from professional practice are always looking at what educational requirements we have to do just so that we can keep people safe. Every year there's something new that is really coming. I talked about artificial intelligence, a little while ago, and that was a big commitment from the organization to train the nurses how to use that intelligence and then put into place a certain care planning process for patients to keep patients pressure ulcer free. So those things are constantly changing.
I would say the other thing, just to add to that, is when we were talking about the nurse of the future, I'm thinking of a phrase that I hear a lot is practice to the top of your license. And I would say over the last 10 years or so, I've seen a lot of different roles emerge within nursing, and I'm seeing scope change, definitely within what our legal scope is, but I'm seeing nurses doing more things that they always could do, but that physicians used to do or PAs used to do. So the profession's changing a great deal. There's a lot of different roles that didn't exist in the past. Care coordinators, patient navigators, things like that. So.
All right. The nation is facing a nursing shortage. We'll have that conversation after the break. You're watching 22 News in Focus. Welcome back to 22 News in Focus. Today we're talking about the nursing profession in the 21st century. Currently, the nation is facing a nursing shortage. So what's behind that shortage?
Well, if we look at the demographic of nurses, the average age of the nurse today is 58 years old, and that's only a couple years away from retirement. In 2008, when we had the recession, a lot of nurses went back to work. Now financials are getting a little better so that the nurses actually have an option to think about retirement. I know at BAYSTATE Medical Center we have a Division of Workforce Planning that really looks at the age ranges of our nursing staff that we have employed, where the most senior nurses work, which is typically in the ICUs, in the operating rooms, in labor and delivery, in the emergency rooms, the highly critically skilled areas. And so we try to prepare ahead of time and figure out in collaboration with the residency, you know, how can we grow our own looking for the future, either with strategies to overhire a little bit in a certain specialty, but really predicting where our nurses are going to be working. And then the advanced care practitioner work, you know, this year we have 28 nurses that will be graduating with their APRN degrees, so they will enter another field of the nursing workforce, and we have to plan for that. I don't know if Brother Michael wants to talk a little bit about the faculty shortage.
Well, I will, one piece before that. I think that with the 2008 crunch of the market, the nurse in the family might have became the one covering the family, carrying the family. So they're staying in practice a little longer than they might have wanted to, because one or the other in the partnership lost their job, doesn't have the same benefits, et cetera. So we stick around a little longer, and that then delays when one retires, which then when it all happens at one time, okay, where's that going to come from? I wasn't aware that there are 28 APRNs, which are 28 openings, and that's a lot of beds to fill. That's
so
a lot.
Stop taking them to train them. I'm just kidding. I'm just kidding. It's a really wonderful benefit that you know, nurses have the opportunity to go on and get a different degree and really be in a different work setting. My own daughter is a nurse practitioner actually, and she got that degree within 5 years out of nursing school, so knew right away that she wanted to go on and do something different. And that's just where, you know, today nurses come out looking for the millennial generation thinks very differently, and they're thinking, what's the next step? What's the next thing I'm going to do and advance in that? When I was in nursing, it wasn't like that. You thought you were going to be in a practice for 20 years. This was going to be my job. So it's very different today.
I think long range, that's exactly the piece. My aunt, who I'll use, was 52 years in ICU at Mercy in Baltimore, Maryland. And went to Mercy School of Nursing, and that's the only place she ever wanted to be. Talk to the students nowadays, 2 years, 3 years, and they're moving to the next wherever. So the long term of being around and having the problem of a potential retirement cohort, I think is going to be much different. The early on is going to be the issue in the near future, because if we can keep them 2 or 3 years, we'll be lucky. If we keep them 5, that would be great, because you're still just a beginner, and you need those years to develop that practice. So.
Are you seeing that there's not enough people also coming out of nursing school, or is it that there is, but they just keep moving up, as you just mentioned?
I think it's a widespread issue. There are just, and Melissa mentioned this before, there are so many different nursing roles today. There's many more roles than when I was a nurse at the bedside. You know, you can work in a private practice office, in radiology, you can be a nurse navigator, you can be an APRN, just so many different roles that we're spreading the workforce out over a greater population and really trying to take them, which is exciting for the profession when you think about all the different things you can do, but it makes it more difficult to manage the care on the inpatient units at the bedside.
I think the other challenge that we've talked about at the collaborative and also here is the average age being 58, that means the faculty are also retiring. So there's a limitation on what you can deliver in terms of nursing students.
The original intent of the DNP, when it started way back, was that how could we get doctorally paired nurses at bedside to train the next generation of nurses? That was the real intent. How do we keep them at bedside? PhDs tend to go off and into an office and leave bedside nursing, but the idea that the DNP prepared nurse faculty member would be at bedside with the students so that we could continue to take groups of 6 and 8 to the clinical setting with the best prepared person, like the best prepared program, etc. They went hand in hand. So it's working. I mean, every year we go through the crunch of looking to fill seats. You know, we had some interviews this past week for my job, etc. So there are those challenges every year, but I think as long as we keep pushing for high standards, we'll have high people at bedside.
There was recently a CNN story that said that nursing schools are turning away qualified students. Do you see that happening? Why is that?
Yes and no. I think it's a two-sided. The issue is that the cohorts have become more competitive. So if I only have 24 seats and it's a competitive cohort, and I say the minimum is a 3.2 to get in. This year they're running between 3.4 and 3.6. So a 3.2, while is a good QPA to get into the program, it's so competitive to get in, I'm only taking the top 24, so those other 12, where do they go? So I think that's what gets lost in that CNN report. I don't think they're truly being turned away. It's that, it's a very competitive cohort to get into.
And I do have to say, my experience when I round on the units and I talk to, some of the students, we have a lot of graduates from the Elms. The nurses that are coming out today, I don't mean to say, are much more well prepared than we were years ago. They are top notch because they are the cream of the crop. I've had a nurse that's been 1.5, 2 years out of nursing school speak to a Joint Commission surveyor with such outstanding knowledge and expertise, really talking about how she's managing the patient's plan of care, that I was impressed and overwhelmed. So we're really proud of the work that the schools are doing and really bringing out very well prepared nurses.
Can we talk about the residency program as well?
Sure, that's actually a great segue that Christine just shared, because we have wonderful academic programs that are supporting our as nursing students, and the nurse residency program is something that will help them to transition from academia into clinical practice successfully. It was in the 90s. It was well recognized by a national healthcare quality organization that was called University Health System Consortium, and then the American Association of Colleges of Nursing, who identified again that changing landscape. And it was at a point where new grad nurses were really having a hard time at the bedside, and with the increase in the patient acuity levels of real sick patients again, and advances in technology, and as you've been listening to the panel, it's all the changes going on. So it was identified, and that's how the residency program that we have implemented in 2013 at BAYSTATE Medical Center, that's when realized the benefit it has for our nurse residents. The program is a year-long program, and as I mentioned earlier, it really encompasses everything that nurse resident is exposed to in their first year of learning. Our president of BAYSTATE Health actually worked for the Healthcare Quality Organization for about 7 years, so it's really nice, as a leader, he understands the high caliber standards that the program holds accountable for the nurse residents, and as well, it was important for our organization to look at, okay, we're going to offer this really great program to support our nurse residents, but we want to make sure that outcomes are impacted. How is this helping them? So the program will track competencies and confidence, and it gives us an opportunity to do a needs assessment and evaluate what additional resources may our nurse residents need to help them deliver safe care at the bedside.
Is bedside manner and communicating with patients something that's not focused on in school? It's more on the...
No, patient satisfaction.
Yeah,
it's number one.
You really... the nurse is a very diverse role right now, and I would say that the students that I teach, I'm assuming the students you teach are the same way, they possess critical thinking, they're scientists, they're very, very smart, but they also have this gravitas and this confidence. And it's funny because I think your students, you'll share with me, your learners will say they're nervous, they're scared behind the scenes, but it doesn't come across. Their bedside manner is calm, and they're very present. It's equally important.
All right. And we will continue our conversation when we return. You're watching 22 News in Focus. You're watching 22 News in Focus. Today we've been talking about issues facing the nursing profession. One potential ballot question is being considered in Massachusetts, and it's the Nurse Patient Assignment Limits Initiative, which would set limits on the number of patients a nurse can be assigned to. Even among nursing organizations, there are arguments for and against setting limits. Opponents are saying that nurses' voices in how care is delivered could be taken away in November if a ballot initiative passes that would establish mandated nurse staff staffing ratios. The Massachusetts Health and Hospital Association said hospitals collectively would have to hire at least 4,500 new nurses to comply at a cost of $880 million per year. The additional cost would force some hospitals to turn away patients, reduce or cut some services, and for some smaller hospitals, close entirely. Proponents say ratios are necessary for hospitals to provide an adequate level of nursing care in the emergency department, medical surgical floors, maternity units, and psychiatric units. The Massachusetts Nurses Association backs the measure, saying it is necessary because nurses are often overburdened and leaves them unable to provide the best possible care and increases the risk of patient falls, infections, and other complications. So let's talk a little bit about what's going on with this ballot initiative.
We actually at Baystate Medical Center attended and gave testimony on Monday at the State House as the issue was being heard with our nurse legislators. And so, do we all want more nurses? We talked about how many nurses we would all really like to have and the issues that we're facing with, nursing shortages in the future. I think every hospital administration really works to make sure that they have the body and the bandwidth of nurses that they need to take care of the patients within the organization. We all have standards in every specialty area where we work to make sure that we have the appropriate nurse to staffing ratios. The issue here is that a patient's not a patient, a nurse is not a nurse, a floor is not a floor. So every patient really isn't equal. I watch our nurses at Baystate Medical Center, and I've seen this as I've been on the night shift, and I actually spending time at the bedside now. I bought a pair of blues, and I spend some time with a nurse in the beginning of her assignment every day, and I see how the charge nurses look at the acuity on a unit and say, this nurse has these 4 patients, 2 of them are sicker than the other 2, so she can manage that piece. Another nurse may have 4 or 5 patients that are at the end of their care and on the way to discharge, so they're not as sick. So they really spread the care out. What we're concerned about is for nursing, someone mandating or a government imposed ratio on our practice takes away our professional practice, our autonomy, our clinical judgment that we were all, you've heard what nurses do, what we're trained to do, how we assess, how we make decisions. Having the government mandate how you're going to practice your practice takes away your professional judgment and your autonomy. And so I think for the nurses, we're really concerned about that piece. The other piece is, should this come to pass, there will be concerns about how patients get access and the ability for us to actually provide that care. Baystate Medical Center is the only tertiary academic medical center in the western part of the state. To say that the care that's provided in that hospital should be exactly as the care that's provided in a smaller community hospital just doesn't make sense, and it's bad practice for that. The issue of the economics, of course, is important. We would have to decide how many patients can we really take care of if we're going to mandate these ratios, and it is a concern that access could be denied for patients. There's no doubt about that.
California is the only state that has voted on this issue so far. Why are some unions pushing for it?
Well, I think across the nation we're seeing the nursing shortage is impacting, and so sometimes the influx of patients can be difficult. Every hospital this winter across the nation struggled with the number of patients coming in through the emergency room with the flu. Our bandwidth to be able to care for that sometimes is stretched, and we really try to make sure that we figure out, what are the other roles that we can put it into the team to really help us take care of those patients. So it is a struggle. California actually did not vote the ratio in. The voters actually denied it. It was the governor that put the ratios into effect in California. So across the nation, people are struggling with that piece, as we're also facing what we're going to do about the nursing shortage.
What cost of human and financial cost would this have on the overall outcome of healthcare?
That's a hard question. You mentioned the $880 million cost for the state of Massachusetts. Actually, just the other day, it's up over $1 billion at this point in time. It's actually up to 5,700 nurses that we would be looking for. And so the piece that we're really concerned about also is if hospitals have to mandate these ratios, what's going to be the impact on the communities? Our long-term care nurse is going to want to work at the hospital. Are school nurses going to work at the hospital? Are we going to be pulling from other states around us? Would nurses travel from Connecticut and New Hampshire and Rhode Island to come to work, you know, in this area? So it is a broader issue that we need to be educated about and need to educate ourselves about, educate our nurses about what this ballot really means for every individual person, because it could impact other areas of the work. It could impact schools of nursing. We wouldn't be able to take as many students as we take now, so it would really impact our ability to train future nurses. You know, we haven't really thought about that piece. So people need to read and educate themselves about, you know, the both sides and really make a decision on what to do.
And I worry too a little bit about, from the professional practice education side, what happens to all those roles we've talked about, that, you know, the growth of roles into care coordination, and, you know, there's IV therapists that are specialized in that, wound care, there's specialties that really benefit the patient. If we need those nurses at the bedside to meet a ratio, I'm not certain that those roles would all exist, because the money and the nurses have to go somewhere.
The conflict of the human capital. We began talking about caring before. How would people that are trained at a caring level be told they can or can't? As we said, it impacts practice. So the human capital and what it would do to nurses, right, to make a choice, to do or not to do, to be behind or not behind, that conflict of caring, I don't see it ending well.
No, I mean, when we think about it, it really brings moral distress to that nurse. If you think about, say we're on a medical unit and a nurse has 4 patients, and 2 of those patients all of a sudden have evolving MI. What is she going to do? Typically today, all the other nurses figure out how they're going to run to those 2 patients and figure out how they can help those nurses. So it's really a 2-to-1 or a 3-to-1, really taking care of those patients that are in a crisis, and the rest of the nurses manage the care of the patients on the floor. That nurse, if this happens, what is she going to say? I can't get the help for my patient? You know, it really makes it very complicated, and I wouldn't want to be the nurse that has to make that decision.
That actually brings me to my next question, too. If we can take a step back for a second, for someone at home that really has no idea about this right now, how is staffing currently determined? Are there any kind of ratios per hospital or in place?
You know, as I said, in Massachusetts, actually implemented in collaboration with the union in 2014, a mandated ratio in the intensive care unit. So we already have 1-to-1 or 1-to-2. That was already actually in a Department of Public Health regulation. So we were just, in effect, putting the DPH regulation into law. A1, which is the Organization for Labor and Delivery, actually, they have ratios. So a lot of this is already in practice. We use our professional organizations to help us define how many patients, you know, a cancer nurse should take care of because patients are getting chemotherapy, how many nurses should be in the labor and delivery area, how many nurses should be in the operating room, in the post-procedural areas. So we're already following standards pretty much. At Baystate Medical Center, we have a shared governance model where we work with our staff nurses actually to figure out what we think we need to do and what we think we need to take care of patients.
All right, we'll have the last word for you after the break. Stay with us. You're watching 22 News in Focus. You're watching 22 News in Focus. Today we've been talking about the changing and challenging roles of the nursing profession. That's our program for today. We want to thank our guests for joining us and thank you at home for watching. If you missed any of it, you can watch it in full on our website, wwlp.com. That's also where you'll find more information about an event for experienced nurses coming up at Baystate Medical Center on our website. Thank you for watching. We wish you a wonderful Sunday.